Hello and welcome to Level 5 Health and Social Care, Unit 504 Partnership Working. And we're now looking at week 3, where we're going to talk about personal budgets and the impact of child abuse. Okay. So the objectives, I've sort of split them up because they're two very clearly separate things. And they both belong in different tasks as well. So we'll try to sort of take them in two halves. This is actually quite a long PowerPoint, so you might want to. There's a very clear natural break where I go from personal budgets to child abuse. Obviously, they don't really relate. So if you want to, you can actually stop there for a while and maybe do some work on the first bit, on the first criteria, and then come back and have a look at it later on because there's 37 slides, so it's a bit longer than normal. So, like I said, it might be too much to take in if you watch the whole thing at once. So please feel free to stop it and then maybe come back to it later on in the week and look at the second half. Okay, I'd say that's probably a good thing to do if you can. Okay, so for the first section of this week's work, we're actually going to look at the objective, which is part of task 2. Explain the role of personal budgets and its impact on working in partnership with service users. Most personal budgets is something that's very international. When I do the bit on child abuse, we're going to very much focus on UK, okay? England in particular. So just so you know. So what are personal budgets and direct payments? They've gained quite a lot of prominence in a range of countries to give people more involvement and more responsibility in their own care and support. The origins of the personal budget go right way back to the independent living and disability rights movements that happened, particularly in Western countries in the 1970s. And it's particularly about the right of people with disabilities to make decisions about, things that affected their lives. Subsequently, the concept of user-directed care, which includes personal budgets, was widened to include other target populations, such as older people and people with long-term care needs. So it's very much in the social care setting. And much more recently, healthcare has been added, which has more complexities due to that where the finance is handled. So most commonly, personal budget schemes are introduced when they're moving towards personalisation. Those of you who've done level 2, level 3 and level 4 with me know a lot about personalisation and know that it's part of the personalisation agenda, which is actually a very important issue. And it's also about developing independence and autonomy by giving people control of the budget to purchase services instead of having it just being done to them. Why introduce them? Primary motivations, as I said, is giving individuals more choice, expanding the options for care, improving outcomes, or this is one that was sort of sneaked in, reducing expenditure. There was a general belief that if you gave people personal budgets, they would opt for things that were less expensive than if it was coming from the local authority or the health provider. Well, yeah, maybe, but not always. Okay. So underlying these motives is the assumption that choice will lead to autonomy, which would improve outcomes. So in other words, people may allow their family to take on more responsibilities, or friends to do certain things, or the local community to do certain things instead of having to put specialist workers in. So you can see where they're trying to save a bit of money. What are the models? There are two models. At one end, they're the open models, where people are allocated just a piece of cash. and they can choose to spend it how they wish, and there's very few accounting mechanisms in place. They probably get their budget probably at the beginning of the financial year. The only condition is that they must obtain adequate care, and there'll be some sort of monitoring to make sure that the care is still adequate. These sort of examples were in Scandinavia, particularly Austria and Germany, this sort of fairly free-flowing one. At the other end, there are planned or budgeted models. There's a bit more of a direct connection between the needs and the goods services published. There may be some restrictions on what the money can be spent on. And it's, you know, the money has to be accounted for. So it might be against an improved spending plan, but definitely records would need to be kept, or there may be limitations on what you spend it on as well. And this sort of type example is you can find it in Holland, Canada, USA, not so, you know, to a smaller extent because you've got the issues with insurances and things, and England. And some personal budgets might have an element of both models. In Belgium or France have managed to create a bit of a hybrid model. Different ways they can be administered. One of them is direct payments, where the individual is a budget holder and they get cash payments, so they'll get the money put into their bank account to purchase certain services. And again, that could be with limitations, and they might have to hand in receipts. That's my experience of it. And I work on a direct payment pilot. A third-party payment body where the budget is held by third-party services, which can be a care manager, a professional, or it can actually be a broker. We had a direct payments team who actually would manage some of the more complex payments for the person if they wanted to. They with our project, they had an option of, it was a sort of 1 and 2 model joined together, where they managed some small bits, but some bigger stuff, they used a broker for it, you know, if they wanted to go to a day service or something like that. The third one is known as the notional budget model, which is probably the one where they have the least involvement. Commissioners are responsible for purchasing services, so they make the decisions, but the individual is just aware of the treatment or service options and how much it costs. So they know how much money there is to be spent on it, but it's the care manager who decides, you know, what service to use. Although they can do it in discussion. It's more like we have a choice of 3. I'm advising this. I want to use this one because, and it's only if the service user objects that would they maybe look at another one. So it's probably number 3. The notional budget is probably the least autonomy for the service user. Number 1's the most autonomy. Number 2 is sort of a bit in between. And number 3 is probably the least autonomy, if you think about it. Some background of it in the UK. We're going to focus on the UK for this assignment. And that's sort of what Qualifi is looking for, really. So they would like you to really explore that sort of impact, personal budgets. So 2007, personal budgets were promoted as part of a new approach. This was followed in 2009 by a pilot of personal budgets within the NHS service and the 2014 Care Act. That gave them a legal framework, as it was identified in both in the acts, to develop these sort of budgets. Personal budget pilot provided for a spectrum of flexibility. The organisation I work for was lucky enough to be one of the pilot organisations for personal budgets, which gave me quite a lot of insight into it, which was very interesting. And the eligible individuals could choose to manage the budget themselves, take direct payments, or use the third party. So for our pilot, we had a combination of the 2. Some people took direct payments, some people used our brokerage system. So what we developed was a little team called the direct payments team, who made sure all that was happening. But they also did the commissioning for the bits where the service user needed them to actually do it on their behalf. Some service users found it very daunting. Some of them were really excited by it. Some of them just thought it was something that they just couldn't handle. So that's why we did the half one to make it available for most people. Some individuals in the period will also use funds to purchase health-related services. We started off with social care services, and then after a year or so, we introduced the healthcare budgets because they took a little bit longer to get organised. And as you can see, the pilot operated from 2009 2012. I was involved in it up until 2011 when I moved on. So after the pilot, care budgets were actually rolled out fairly quickly, and health budgets were actually rolled out from October 2014. And that was agreed for all individuals who are on a continuing care health plan, really. So people who basically had long-term health problems, not if you just had acute care, like after breaking a leg or having an operation. It wasn't really for those sort of services. It's for people who had long-term services. They tend to have long-term disabilities, physical disabilities, or if they were older people with health issues. So central to the scheme was the care plan, as it always is. And individuals can choose to manage their personal budgets in different ways. They've quite a lot of freedom, really, bringing in the services. So it could be, but the sort of services people looked at was like support at home, helping you manage maybe you're having difficulty cooking or having difficulty doing the cleaning. So that sort of social care support, or wanting someone to take them out to the shops so they can actually get out there. Some psychological therapies, maybe some counselling, or maybe some support with managing depression, things like that. Physical therapies, that was quite a lot. People liked the idea of paying and having control over a physiotherapist, so people could maybe book with a local physiotherapist, a private one, where they knew that they were seeing the same person all the time, and they could book someone who lived quite near to them, or who would come to their home, various things like that. So also some nursing services, well, people could come in to change dressings, various things, if they had a long-term issue, or people managing some of their medication maybe on a long-term basis. Transport services and leisure activities. If it was good for someone's sort of mental health to actually, get them down to the out to the local park sort of once a week, so they could, have a bit of fresh air and get out and about. And maybe they didn't have proper transport for it, they could pay for that sort of service as well. Leisure activities could be like going to a specialist swimming group, for people with physical disabilities, where they had, like a pool that was adapted to enable people to get in and out of the pool from wheelchairs and things like that. And you might pay for a special session, or even a one-to-one session. These budgets were typically determined by using something known as indicative budgets. They're based on best estimates. So what we really did was, well, for the pilot, we did people who already had services going in, because we knew the cost of their care package. So we used that as the indicative budget. It was much more difficult when we had new ones, but what we had to do was to sort of cost it up in the way that we would have done previously for a care package, and then use that as an indicative budget. Lots of costing tools were created to help you do this over this time as well. So people chose to adopt certain tools as well. Things to think about. By allowing the individual, obviously, personal budgets can actually offer a lot more choice and control to the service user. They feel they've got more control over their life. Some of the things that could be a problem, if there is too much choice, that could be really confusing for the person. Like, how do I make a choice? What do I base my decision upon? If people are unable to get the relevant information to find out what choices are out there. So that's really important to provide information. There can be some difficulties where when you're working with maybe your care manager or your social worker or your carer, they may have a different view from you, the service user, as to what might be good for you, as to, or you might choose an organization that they think isn't very good, or the other way around. And that can cause a little bit of difficulty. The money can be used in a more flexible way than how health and social care can sometimes provide. There is a risk of them choosing services that increase their problems rather than decrease them. And some people could spend their money in a way that doesn't conform to the current understanding of evidence-based medicine. Now, that's always been an issue, really. People wanting interventions that the medical profession aren't too keen on, such as maybe complementary therapies, using acupuncture, using alternative healing, such as Reiki or things like that. So now you may, or homeopathy, you might have a sort of quite a strong belief in it as a service user, but you'll probably find out most doctors will say, well, there's no evidence it actually works, so it will annoy them if you want to spend money on it. But then, for some people who believe that an acupressure massage can actually help make their muscles feel a lot better, and they maybe have tried it and it worked for them, it becomes a bit of a difference. People can say, well, I don't, this is a medical condition, how can it do that? So I'm sure you've come across this, and you've come across people with different beliefs, and that's always been a bit of an issue, really. Also, increasing choice is accompanied by a number of responsibilities and constraints, really, because as a service user, you're responsible for the choice you've made, and it is, after all, money that's been given to you, so you have to take some responsibility for it. What support is needed, really? Some service user groups need a lot more control and oversight, particularly those maybe with learning disabilities, people with mental health problems, people without the ability or capacity to manage a personal budget themselves, well, can be at risk, or they could get excluded, and that's a problem. So the important thing there is that they will need a support team, or they would need someone, or maybe a care manager could take responsibility for guiding and supporting it. And that's sort of what we had to do. But we also brought in advocacy services for people who felt that they didn't want to be guided by the care manager because they felt the care manager might tell them, what to choose. We brought in advocacy services who were fairly neutral, who could work with the person and help them sort of, weigh up the pros and cons of things. So I've said the need for support can really vary differently. Older people and people with very complex needs may need much wider support than one of the groups that has always been incredibly successful doing this is young adults with physical disability who don't have any mental health issues, who don't have any sort of brain damages or anything like that, and not just physical disabilities, but mainly physical disabilities. And they've often proved to be incredibly capable at doing this, and very good at making decisions and very clear about what they need, because most of them just want to get out there, really. And they want things to help them get out and about and be part of the community. So that's all I've done on personal budgets. The information that I used was from a chapter from a book, Achieving Person-Centered Health Systems, so chapter 10. I've actually put the full chapter on your resources so you can have a good look at it in your own time and read it. I put some other bits of research in your resources as well. And you might want to just pick out what you need to answer the criteria. Now remember, you only need to focus on how these changes can affect partnership working with the service user for professionals, paid carers, and informal carers. And I've put a document about working carers and how it affects their partnership with the service user. So you'll find that there in your resources. Okay. So have a look. So don't really give me too much about how it works, how these changes could affect partnership working with this. It's about you make sure you focus on working with the service user. How can it affect how can it affect your relationship with the service user as a professional or a paid carer or an informal carer? So think about those of you who are in work placements, think about your role with the service user and if they were managing the money for choosing maybe the care home they were in or the care service they were getting, if they had control of that money, how would that affect your sort of relationships? Okay, so that is the focus of that criteria. Okay, so as I said, you might want to take a break here because the other slides are a lot longer on child abuse. And when you're ready, you can just go on to the next section. Hello, welcome back. We're going to look this half of the PowerPoint really looks at the impact of child abuse inquiries on government and working in partnerships. So again, the focus, there is an awful lot of information out there on child abuse. The focus is like how the government has responded to some of the issues that have arisen around child abuse, and most importantly, because they've responded in a million different ways. And if you wrote up on that, you know, the whole assignment could take this up. So we're only looking at the element of partnerships, okay? Government responses that relate to partnerships, okay? Again, if you're unsure, you know what to do, just WhatsApp me and we can talk about it a little bit further. Okay, let's just go on then. So the objective is, this one's actually part of task 3. So remember that, don't stick them together. This is part of task 3. 3.1, evaluate the impact of child abuse inquiries on government thinking on working in partnership. So we're going to look at some of the highlights. They're not really highlights, they're lowlights really, unfortunately. We're going to look at the child abuse issues that really sparked government thinking changes or onward change. And we're focusing particularly on the UK, okay, mainly England. Now, I've done a little overview of the history of child protection just to bring you up to speed. And I'm going to name a few cases which you can look up in more detail elsewhere. I'm not going to go into them because we don't have the time to go into the details of the case, but if you're interested in any of them, believe me, they're all Googleable. You'd find them. Just because I've only highlighted these cases, unfortunately, please don't think they are the only ones. There are a lot more in between, but I've picked the ones that have had the most publicity. So you'll be able to Google them and you'll get a lot of information. but also because they're the ones that really caused some sort of change or review in government documents, legislation, guidance, that sort of thing. Okay, so please don't think, unfortunately, there was nothing in between. I'm afraid there was. So just to be aware. So we're starting off in 1948 with the Children's Act, which is the first major piece of legislation which is related to child protection. The Children's Act, the original one, you can't get hold of; it's too old. Set out new support measures for children across the UK. Under the Act, local authorities, like the council, had a duty to provide care for any child whose parents were unable to care for them. This was in the child's best interest. So that's really where child protection and children's services really kicked off. Okay. These sort of pottered along quite well. And then in 1973, they had to make some reforms to the child protection system because they identified that it was failing. So at the age of 7, Maria Colwell was killed by her stepfather after being returned home from foster care. She'd had some problems. Family had some problems, should I say, and the child had been sent out to foster care for her own protection. The family sort of gave the impression that the problems had settled. The child was returned from foster care to the family, and she was killed by her stepfather quite quickly. There was a public inquiry, and it was identified that she had been felled by the child protection. So the system, either decisions made or the way the teams worked, had let her down. So there was a need to improve the system and the development of stronger measures to enable professionals working with children to recognise and respond to abuse and neglect. Okay, so there may be elements of training, there might have been elements of communication, all sorts of things, which caused the Children's Act to be reformed in 1975 and legislation created to meet this. Further history, 1984, Child Protection Services were reviewed again. Further changes were prompted partly to inquiries into more child deaths over that period of time, including, just as I've just picked this one out, a 4-year-old child named Jasmine Beckford, who was again killed by her stepfather after being returned home from care. Same situation exactly as the previous one. She was removed from her parents, mother and stepfather, because of concerns of her safety. She went into care support, and when they got the impression that things had settled down, she was returned and her stepfather killed her. I'm sure you can see a pattern here, and it makes you sort of think about, well, what would you assess about the relationship with the stepfather and their children and how they felt about things. I'm sure you could work it out. Anyway, the first working together guidance was published in 1988, and this again was a bit of a reflection on the Jasmine Beckford case, because it was about looking more at the procedures and how agencies work together. That's why it's called working together. And they also introduced something known as serious case reviews. So when you had something like serious level of abuse or death, like in this case, couldn't get much more serious, they would be identified as serious case reviews, and they would have very sort of formal inquiries in the local authority, including the partners, and they would be documented for the first time. Okay, so working together guidance about partnership working. It was the first time they identified there was something not quite right about the partnership working. 1990, the United Nations Convention on the Rights of the Child was identified, which sets out the rights of every child in the world to survive, grow, participate, and fulfill their potential. So picking up on some of that, and the review of the Children's Act in 1989 about the interagency cooperation, they had to change the working together guidance a little bit more because they changed the Act a little bit. And guidance had to be followed by local authority social services departments. So it became very clear legislation. It wasn't really just guidance. It was, this is what you've got to do. Okay. 2000s, we had the death of 8-year-old Victoria Colombier following abuse by and neglect by her great aunt and her great aunt's boyfriend. A little girl who was born in Africa and was actually living with her, I think her parents were actually in Africa, and she was living with her great aunt and great aunt's boyfriend. And it her death was terrible. The amount of injuries were absolutely terrible. You can look this one up if you want. It was pretty awful. However, it was unfortunate. She was known to social services. She was known to the police. That was identified by neighbours who had said that they had concerns. Housing, health. She'd been in and out of casualty. Even her church were aware, and yet somehow nobody managed to save this little girl. So it contributes. So Lord Lamming was asked to do a report, and he really set out some real sweeping changes as the way the services were structured. 2002, there were more reforms to child protection legislation. This was a bit different. This was about introducing things like DBS, which is a vetting process to look at people's backgrounds and criminal convictions and that, because that didn't really exist beforehand. And this was about a guy who was a school caretaker who'd actually previously been investigated by police for and committed crime. He committed burglary, indecent assault, and rape, and yet somehow he got a job as a school caretaker. And he ended up taking these two little girls from school and sexually abusing them and killing them. So that was the sort of legislation again that was strengthened about protecting children from adults who pose a risk. So if you have a criminal conviction, you won't be allowed to work with children now. Had we had that in place, he would never have got the job. He wouldn't have been allowed to be in the job. 2008, the case of little Peter Connolly, known as Baby P. You'll often see it known as Baby P. He was only a year old. Following abuse and neglect by his mother, her boyfriend, and her boyfriend's brother, who all lived in the same house. There was a further review. So Lord Lamming was asked back to review his report and do a progress report on the report that he did after the Victoria Colombier case. He did a progress report that identified that there hadn't actually been a lot of progress, unfortunately. And he made 58 recommendations of change. I have put his report as part of your resources for you to have a little look at. In 2010, following Lamming's report, they revised working together again, okay? And the serious case reviews, there was an agreement they were actually going to be published, so that meant anyone from the public could get hold of them and look at them. And the idea was to hold people more to account, really, and to sort of say, so people knew what was going on. They felt it would be more transparent. So the working together to safeguard children was, as I said, was revised. And again, there were issues. Quite a lot of Lamming's 58 points were about partnership working. There were other things, of course, but we're going to focus on the partnership working. 2013, there was a review of sexual exploitation in a town called Rochdale. And again, the working together guidance was updated. As you can see, a sort of you can see a progress here, can't you? Independent review into the child sexual exploitation. And this is a bit different, really. This is young women who were in care, who were being picked up and groomed to be sex workers by a group of guys in Rochdale. 47 girls were actually involved in this, and it became a massive scandal, as you can imagine, an absolutely big national scandal. So this wasn't about one abusive stepfather. This was about a gang of guys who did this on purpose, who were basically using these girls for sex, grooming these girls, making it that they didn't really know any better, picking them up at quite young age from care homes, taking them from care homes, dropping them back again, picking them up, taking them away. It's quite a thing to read, actually, if you want to read about it. Absolutely shocking. But again, a new version of Working Together was created in 2013, constantly trying to tighten it up. But one of the big issues here was again about partnership working. It was saying that, the police and the council are just not working together, not telling each other anything, or when social workers are asking the police to act, the police don't act because they didn't, there was quite a lot of issues about the fact that these young girls were in care. So according to the police, they were troubled anyway. And the general assumption was, well, they were probably naughty girls anyway, so they were going to do things like this because they were from bad backgrounds and poor upbringing and such like. It was a massive sort of assumptions made about these young girls, should I say. So yeah, I mean, it's worth a read. It's pretty horrible, actually. So 2022, this is the last one I'm looking at, a safeguarding practice review. So there's always been a safeguarding panel which was identified. So they did a practice review into the murders of two children. They're not related, but two things that happened within the same time. Arthur Labino Hughes and Star Hobson. And they examined the circumstances leading up to their death. And again, identified weaknesses in the local safeguarding partners. So the practice review is another document that stands along with Working Together. And I've made that available for you as well. So what went wrong with Arthur and Star? I can't go through all the other cases, but I said, please do have a look. But as it's the most recent one, we'll look at that. What happened to Arthur and Star? There was weaknesses in information sharing and seeking. So people didn't ask things from other agencies and people didn't share things from other agencies. They remained in their little silo. So I know this, but they didn't tell the social workers. They didn't tell the hospital didn't tell the police, There was a lack of robust critical thinking and challenge. So because the police make one assumption, nobody challenged them, or the social workers made a decision and no one else challenged that either. Oh, let's let them stay with the family. All the other involved parties should have been challenging and saying, there was a failure to trigger multi-agency child protection processes, which we've spent years on refining, but they just didn't trigger them. There is a need for sharper specialist child protection skills and expertise. So that is a training issue. And that's particularly across the board where there may be some good training in the social work teams, because obviously it's been part of their role for a long time. It's not always considered part of the training for the nursing team. But if you work in a children's ward, if you work in A&E, you do need some idea about knowing that there's a possibility of abuse, because you might be the first people who see it. You might need to be the one who needs to report it or investigate it. It's the same with the police as well. Things might get reported to the police, but they might not know what to look for. So there is an issue for training, but there's an issue for sharing as well, for being a community of practice or something like that would be quite valuable, wouldn't it? Where you could actually share your ideas and knowledge. Underpinning these issues is the need for leaders to have a powerful enabling impact and creating the optimum. So it's about making it possible for maybe people to meet across the team, so that, the police and the social workers, are they giving them time to actually set up meetings? Are they giving them a space to do it? Are they making them a community? Are they allowing them to be a community of practice? Or, these aren't new issues. They come across the reviews regularly. They come up in all analysis of serious case reviews, and they featured in all those previous inquiries into child deaths. So those 4 issues have come up in all of the inquiries that I have highlighted to you over the years. So something hasn't changed. Or that's unfair. It may well have changed, but not enough. So let's look at the Lamming review again. As I said, he found 58 points. I'm just going to focus on the ones on partnership, and there's plenty of those, unfortunately, but they're good for you to know. So he's identified with the fact that starting at government level, there needs to be more energy and drive in implementing change. The government needs to know what's going on and needs to sort of, be checking in, and they need to put an emphasis on it, not just saying, oh, well, do the Lamming review, but it needs to be something that gets reported back to government. And he's saying they should establish a national safeguarding delivery unit that reports directly to the UK Cabinet and then annually to Parliament. And only that way will these things, be considered to have the level of importance. This multidisciplinary unit must be led with someone with great authority, specialist knowledge, and obvious ambition to improve the outcomes. It needs to be a flexible and agile team which can draw on staff with direct frontline experience from across all the different sectors like police, health, children's services, along with civil servants from central government who can actually act quite quickly on it. So if legislation needs to be drafted, they can help with that sort of thing. If guidance needs to come out from the government website, they can help with that sort of thing. Another thing Lamming said in his review was there needs to be training for partners. The Secretary of State for Health must immediately address the wariness of staff to engage. Most people, apart from social workers who know it's part of their job, are wary of engaging with child protection. They don't want to get involved because it's frightening and it's murky and it's stressful. So people like GPs, community nurses, and paediatricians must be helped to develop a wider range of skills. And then one of the areas it has been identified is particularly in health staff. It was never particularly part of their training. And of a greater challenge is the need to assess the status, training, and responsibilities carried out by health visitors. Bearing in mind that health visitors are the people that visit children when they're very small and young, and they visit them at home, and they know the circumstances. There should be some very much clearer training on child protection and child abuse. Now, one would think that, gosh, we probably all thought it's part of a health visitor's role anyway, but it seems that he felt that there wasn't enough. Home Secretary must urgently address the adequacy of the resources devoted to police child protection teams. Now, across the country, police child protection teams, some of them have specialist teams, some of them don't, some of them have maybe an individual, some of them have a limited amount of training, some of them have quite a lot of specialist training. But there are also issues with the police, vacancy rates. The status of this works is not about well, I would say it is about catching criminals. You might have a view too, but it's not the sort of work that the police see. I think they think it's more social work, and they should be out catching burglars, and bank robbers and things like that. But actually, it's legislation, so police need to act on it. He did identify has been a lot of progress in interagency work. So even though it's quite poor, he has said that over the years progress, especially since his last report, and it's driven by the local specific safeguarding children's boards and the multi-agency teams who work with them. But there are still problems. The difficulty of working across organisational boundaries and cultures. And it's really about how much their managers probably support it. Sharing information is still a weakness, and a lack of feedback. So if someone raises a concern, it disappears into a black hole. They might act on it, but the person who raises it might never know. So they don't know if they should do more, less, or whatever. Joint working between children's social workers, youth workers, schools, early years like nurseries, police and health often depends on the commitment of individual staff, he said. And sometimes this happens despite rather than because of the organisational arrangements. And he felt this had to be addressed. So if someone really cared about it, they made it happen. But maybe their organisation didn't really give them, support up. So they found their way around it. So some of the principles he set out from working together. Child's welfare is paramount. Children's wishes and feelings are sought and heard. Children's social care works in partnership with families. So remember about the partnership with families as well. Children are raised by their families in a family environment wherever possible. Now, there's always been a bit of an issue that sometimes some people feel that maybe they go overboard in that too much and leave a child at risk. Local authorities work with other agencies to effectively identify, meet needs of children, and local authorities consider the economic and social impact. So they need to see what their situation. They're thinking not just about the child as an individual, but what's going on in their background, what's going on at home, what's safe, can they even afford to eat, are they living in poverty? Because all these stresses can add and bring about child abuse. Okay, so this is working together. 2023 is the last review, most recent review of it. So you can have a look at that as well. Expectations for multi-agency working. Strong multi-agency and multidisciplinary working is vital to respond to the needs, and the following expectations have been developed. So again, this is about all the different actors, police, local authorities, health services, working together, and they work in a very clear structure. The expectations are structured at 3 levels. So what Lamin has identified here was he's given what each level is expected to do. So we've got strategic leaders who could be chief execs, chief constables, police and crime commissioners, chief executives of schools. They had expectations. I'm just focusing on maybe the more hands-on people. So senior and middle managers, maybe directors of children's services, heads of services, and the expectations on them is to collaborate, that decisions are based on shared practice, to learn, to make sure that their teams have time to engage in peer learning. So this is maybe our communities of practice, things like that, or maybe some formal training. Peer audit, group supervision and observation. Resource, making sure they get the support they need, drawing in expertise from other agencies. Again, hopefully IPL, IPE nowadays might help towards that, because if there's some understanding of the work that other people do, it might help. Include, Managers support staff to identify and challenge discrimination. Mutual challenge. So challenging within your own agency and across agency, actively encouraging challenge. So to do that, they need to have these times when they can talk to each other. Valuing independent judgments and giving them space alongside collective decision making to avoid groupthink. So that's about making sure that people's individual views are taken into account. So hearing and listening, even if the rest of the group doesn't agree, you should always listen to the one that maybe has a slightly different view because it might be a different insight. It's time consuming, and that's what I think that's why sometimes it's gone wrong. Those in direct practice, like frontline social workers, health visitors, police constables, teachers, what's expected of those? It's still the same thing: collaborate, learn, resource, include. Collaborating is it's mostly about sharing information and making sure that they all got the child at the centre of what they're doing. Learning, we're talking about communities of practice, we're talking about IPL here. Drawing on the best available evidence from their individual fields, sharing their diverse perspectives. Resources, builds in strong relationships, either formally or informally, including practitioners recognise the difference between a confident response to circumstances where people experience adversity. So it's about looking at their backgrounds, what sort of harm they could face because of their background, what family stresses are going on. And even the police should be trained to notice that. Mutual challenge, challenging each other, and seeking to resolve their differences of opinions in a restorative and respectful way so that people feel valued and feel safe. Because if they don't feel safe to challenge and share their views, if people ridicule them or ignore them or put them down in a way, then that worker won't come up with the insight that might be the one that saves the child. Information sharing, as you can imagine, is a big issue. No single practitioner can have a full picture of a child's needs. So all reviews and safeguarding practice reviews has highlighted that missed opportunities to record and understand the significance of. So it's about recording things and then making sure other members know about it, really. But if you don't record it in the first place, you've got nothing to share. Sometimes, again, social workers are probably better at recording because it's what they do all the time. But if you're a busy nursing casualty and you see something, if you have concerns, record it, and at least it might get picked up later on. Practitioners should be proactive in sharing. So don't hold on to it and wait for someone to ask for it because they won't know. So make sure that you share information whenever you can and all sorts of information. So think wider than just a child that's in front of you. What's going on with the adults around them. Has one of them just been arrested? What for? How will that impact a child's safety? It's also essential for identifying patterns of behaviour when a child is at risk of going missing. And this is like the Rochdale issue. The children were getting picked up, taken away from the care home. Nobody knew that they weren't there. They weren't going to school. They were picking them up before they got to the school gates, and they were bringing them back at 4 o'clock to the care home without asking the child, who was told not to say anything. School wasn't really recording that these young girls were not turning up. So it's about think about our children in a location of risk where several children are doing the same thing together and then they're all missing. You need to be looking at that. What is going on? It's for local safeguarding partners to consider how they build relationships. But obviously, as you can imagine, the relationship with schools are really, really important. How can you do that? You can't always have all the school teachers at all your partnership meetings, but if you've got to find a way that education is represented, and you've got to find a way that if you're a policeman and you keep seeing these kids, that you need to be able to communicate with school and say, why is this kid not at school? How often does this happen? Statutory safeguarding partners identified partnerships as the local authority, the council, an integrated care board, which is the health aspect of it. Some areas have actually got integrated boards, which is health and the local authority together. Chief officer of the police for an area. And these three partners have a joint and equal duty to make arrangements for people to work together as a team. So all of these three partners are responsible. So basically, the local authority, health, and the police are responsible for making sure that their staff carry out their safeguarding roles and work together. Every local authority will have a multi-agency safeguarding arrangement, and there's quite clear vision about how that goes, and it really rehashes some of the things that we've just been talking about. It's about how we improve the outcomes, how we respond when a child is possibly suffering, how we challenge each other, how the children's voice is actually being heard, really, how information is sought and shared, how it's actually collected in the first place and shared, and how the leaders have actually promoted and embedded that learning from each other culture, and what maybe they've used. Have they started? Have they got sort of multi-agency groups, or are there any vacancies that need filling? Those sorts of things. Have they given people time to actually do some networking? So the local partnership should set out and then publish arrangements, um, who they require to work with them as relevant agencies. This will be all local education and childcare providers who work with children up to the age of 18. Um, they must be included too. And sometimes they got a bit forgotten along the way. But obviously, the child spends most of his life at school, so up to the age of 18 is pretty important. So that's been set down now in document. Local protocols, there need to be very clear arrangements for how cases will be managed, who's going to do what. This is about accountability and responsibility, really. Who's going to be a lead practitioner? So part of the process of the safeguarding thing is writing that down, making a note of it. What are the governance arrangements? How are they going to, what are the decision making protocols? Is there a specific group for that? Does it happen on a certain day? It's all got to be documented. What skills and knowledge is required for lead practitioners' roles? So you might have a lead practitioner in social work. You might have someone who takes the lead in care. You might have someone who takes the lead in the police. Do they have the skills, knowledge, and competence to do this? Can they be there to support maybe other police constables who don't know as much? They have to be trained well enough. Case audits need to be looked at. There is a process that they're expected to do where they actually audit the cases and identify learning from the cases. Hopefully, not all the children die, but there are other issues that arise, and those cases should still be looked at regularly. There should be a clear, documented process from how you undertake assessments, across the board, and how the partnership works to assess, what level of abuse is taking place. So it's all about putting out the processes. Okay, like I said, I'd like you to look through these documents, the two reports, the Child Safeguarding Practice Review and the Protection of Children in England, a Progress Report. That's one of them is the Practice Review and the other one is the Lambing Report. and then have a look at working together, the 2023 working together, because that's a response to the Lamin report. So therefore you've got the issues and you've got the government's response to them, which should answer your criteria. There's a heck of a lot of information there, and you're going to have to bring it down to a smaller amount. Okay, so you're going to really have to pick up the highlights. Do Google the cases. I've highlighted them for further details, but be warned, you might find them quite upsetting. But again, if you want to read about them, just to, you know, for your own understanding of what can happen. One thing it very clearly identifies all the way through all of these cases, that partnership working is generally what failed a child. Okay, and I think that's really important for you to know. There was other stuff about knowledge and, you know, and processes and procedures, but really the partnership working, you know, loomed high in nearly all of these issues. So that's worth mentioning. Okay, so this is the end of this week's work. Do take some time to have a look, and like I said, don't forget, you know, it's probably worth looking at these bits separately because it's a bit too much. Okay, I will see you for week 4. Goodbye.